This week on the BackTable podcast.
Biohazardous waste is so expensive and it's so carbon intensive because it either has to be incinerated or it has to be steam autoclaved prior to being disposed of. So we're really taking all that waste from throughout the hospital and sending it literally into the air one way or the other. But there's actually very little that needs to go into the biohazardous waste containers. And a lot of people don't know that. So at my prior hospital, through education and through some initiatives in the operating room, we were able to cut our red bag waste down to 1 kick bucket per case.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. This is Mark Hoffman. I have Dr. Amy Park with us as well, and we are excited to bring another amazing guest to the show, Dr. Kelly Wright, who is Director of the Division of Minimally Invasive Gynecologic Surgery at Cedars-Sinai in California, and we're going to talk today about waste in the operating room. Welcome to the show, Kelly.
Hey, thanks so much for having me.
Dr. Wright, but I've known you for a long time, so forgive me. You and I are normally on a first-name basis, so I can refer to you in front of all these listeners as Dr. Wright, which is the professional way to do it. But
yeah, I'm comfortable talking to a friend.
Okay, well, no, I appreciate that, and it means a lot to have a good friend like you join us today on the show. And Amy here is joining us from Cleveland as well.
So happy to see you, Kelly. Thanks for talking to us on this really important topic of sustainability in surgery and how we can do things better and what the impact is, the scope of the problem. I mean, I'm just really interested in hearing all your thoughts.
So, Kelly, can you do me a favor and just introduce tell us about yourself, how you got to where you are, both clinically, but also how you got to become interested in understanding OR waste?
Yeah, I think I didn't anticipate making trash my passion project, but it certainly has ended up that way. But I'll tell you a little bit about my clinical background. I am from Texas, went to college and medical school in Texas. Actually, my undergraduate degree was in biomedical engineering. So I always had kind of an interest in efficiency and processes and how things are developed and where they go. But that kind of culminated in a residency in OBGYN at Brigham and Women's, and then a fellowship in minimally invasive GYN surgery, because I thought that was just a really fun field, something really sustainable and something I would always want to practice and get better at throughout my life. And I've been out of fellowship for 10 years now and spent the first 5 years of my career at the Leahy Clinic in Boston and the next 5 years at Cedars-Sinai, where I've been serving as the division director for the past couple years. And it's been a lot of fun. I think what has really prompted my interest in medical waste and is, number one, if you're in the operating room, you're around it all the time. And so throughout our training and then working as attendings, I mean, we just see it day in and day out, and it starts to become really overwhelming. I think I expected when I moved from Boston to California is the land of green and everybody wants to be sustainable and everything is recycled. And that's completely not what I found. Southern California in particular, very heavy on the fossil fuels. And even coming into a new hospital and seeing that we not only did a terrible job of triaging our waste overall throughout the hospital system, but also in the operating room. Seeing that the waste wasn't triaged and seeing all the things we were throwing away and all the things we were using that was disposable, which, funny enough, was actually much more than my prior institution in Boston.
But when did you start thinking about that, though? That's something, it sounds like that was on your mind in Boston. It was something that was on your mind when you came to California. Like what brought that to your attention?
Well, a couple things. I have to commend my former hospital for going through some changes that were actually based on finances. I mean, this sustainability in healthcare is one of the places where doing the right thing is actually financially beneficial for the institution. And we had taken measures to cut waste in the operating room and really do a good job of triaging our biohazardous waste simply for the cost savings. So I started to think about it during that time.
And when you say cost savings, are we talking about making sure because how waste is processed obviously costs money, but there are different ways to process waste, right? Like there's not just doesn't just go in like the same dumpster that, our garbage in our house goes to, right? So like,
right. We can't just set it out on the curb and somebody comes and gets it, So hospital waste is classified in a couple different ways, but one of the biggest and most cost intensive and most energy intensive is the biohazardous waste or the red bag waste, which we all know because we all see it in the operating room. Biohazardous waste is so expensive and it's so carbon intensive because it either has to be incinerated or it has to be steam autoclaved prior to being disposed of. So we're really taking all that waste from throughout the hospital and sending it literally into the air one way or the other. But there's actually very little that needs to go into the biohazardous waste containers. And a lot of people don't know that. So at my prior hospital, through education and through some initiatives in the operating room, we were able to cut our red bag waste down to 1 kick bucket per case. So that's a significant cost savings for the hospital.
And what was it before the initiative? What was the before?
Yeah, it was just having, one of those big containers for red bags in the OR. And if you're not careful, of course, you can just take the entire field
toss it in. Yeah.
Toss it into the bin afterwards. So seeing that initiative, seeing that it worked and knowing what really needs to go in per the Department of Public Health was something that was really meaningful for me and knew that I was making an impact. At the time, financially, I really didn't know how environmentally friendly it was to better triage waste until I came to my current institution and learned the actual environmental impacts of the red bag waste. So that's really how I got interested in it. And, the more you learn, it's like in everything, the more you learn, the more you are surprised by things. But it turns out that this is happening all over the country and that hospitals are typically the biggest waste producers in their communities. So if we want to talk about being good neighbors to our communities, actually providing care in our communities and not affecting our patients negatively, we need to do a better job of watching our carbon emissions.
No, and I read your recent article that was written by you and Amy and Dr. Louise King and is it Elliot Richardson, who is another author?
And K.S. Schwartz, our resident.
Yeah.
Mm-hmm.
So such a nice intro for those of us like me who care about these things. It's just nothing that had never popped in my head. So definitely our listeners should check that out. But Amy, I'm sorry, what were you going to say?
I was just going to mention that I actually got super interested in this topic because I was inspired by Kelly's tweets, the work that you were doing. And I think that those are what you describe about the red bag problem is something that we all have control over as surgeons in the operating room. So I think disseminating what actually the choices that we make in terms of just cleaning up the field and what trash can you put it in is super impactful, number one. Number two is, just in terms of the instruments that we choose, the modality of surgery, there's so many aspects to it that I think, I'd love to just pick your brain on all of that. And then circling back to the impact that hospitals and healthcare has in terms of waste in the community, I remember bringing in this team, this human factors team. You guys have a great human factors team at Cedars-Sinai too, actually.
We do.
With Tara Cohen. But in any case, this human factors team was just bowled over by how much waste. And I had already just internalized the field in terms of, the drapes and all the disposables. He was like, gosh, that is so much waste after each case, bags and bags of waste. But you're right.
And all I can think is that I need to Google if University of Kentucky has a human factors team. I don't even know what you guys are talking about. So that's
Oh
something,
yeah. No.
something for me to look into.
Yeah, Kelly should describe. You describe it, Kelly. It's pretty cool, actually.
Oh gosh, it's how. Oh, I don't know the appropriate definition, but the best way to describe it is like air traffic control, and what allows an air traffic controller to do their job without making mistakes because the stakes are so high. So it can be the same thing in the operating room. How do you optimize an environment to take the human factors or the propensity for error out of the equation?
Oh, so like systems management, like designing sort of people-proof systems in healthcare, right?
Yeah,
Like,
that's probably a more eloquent way to say it.
Something that people say about me all the time. Okay, so Amy had a few sort of thoughts there. I guess I'm going to make sure we get to her questions here. So Amy, what was your first, you gave kind of a list of questions.
Well, can you just tell us, like, can you make an analogy of like how much waste is a hospital system putting into the community? Like, is there a quantifiable amount that you can give an analogy for?
I'm not sure I can quantify it, but when, you find out that a large hospital or tertiary care hospital can be the biggest waste producer in their community. If you think about what else is in LA, what else is in a large city, you've got stadiums, you've usually got college campuses. And to think that the hospitals are typically the ones putting out the most waste in that system. And that waste has to be processed. So it's either going to a landfill and you have to consider the neighboring communities where that's going. Or as I mentioned, if it's processed waste, needs to be incinerated or steam autoclaved. And so that's directly, putting particulate matter into the atmosphere, either through energy use or through direct incineration. So it's really astounding when there's no direct comparison of the impact of hospital waste on communities, but there are a lot of comparisons looking at traffic-based air pollution, airport-based air pollution, and things like power plant air pollutions on local communities. And those have been found to have some really significant health effects, all the way from obstetrical outcomes. Every negative obstetrical outcome you can think of can be tied to particulate matter in the surrounding area. But even there's more and more research into things like heart transplant and bariatric surgery, and being able to measure the success of those patients on how much particulate matter they're exposed to, how much air pollution they're exposed to. So it's really astounding. And I think our fields are going to look more into these environmental factors and the success they have, or their impact on the outcomes that they have on our patients, rather than what we can do in medicine to affect those outcomes.
So this is basically an issue that we're contributing to, and then if we can do something to mitigate this problem, we can, in effect, improve the health of our community and our patients.
Exactly. I think a lot of us don't realize the overall carbon impact of healthcare, in the world and in the US. So a lot of us focus on aviation or the automotive industry. And it might surprise you to know that global healthcare puts out almost double the emissions of global aviation every year.
And one of the things I was reading about for this was that a robotic hysterectomy produces as much carbon waste as driving your car 2,200 miles. So I read that was
right.
Was like, and we're trying to be, we're trying to help everybody and do good things. And our intention is to provide the best care for our patients based on, this, looking at this small circle of data. But when you start to expand our impact, not just in hospital length of stay or blood loss, that's where reading all this stuff has really made me take a step back and realize you keep thinking you understand how systems work, and you have to take a step back and take another step back and realize all the ways, all of this, we are part of this ecosystem, and it all impacts everything.
Speaking to that, I think when we're in the hospital, we see the areas that we think are the most carbon intensive. We see the waste, we see the energy and the water that we have to use, the ventilation that we have to have. It seems so intensive. And then when you read more about it, you learn that a significant portion of emissions in healthcare comes from supply chain. So basically the manufacturing, the distribution, the use, and then the disposal of single-use products, most of which are plastic or petroleum-based. So significant amount of fossil fuels coming from that heavy burden of single-use objects.
So there's so many steps in the process of getting that stuff from the warehouse. I mean, just making it from the factories to the warehouse to getting it to us into our hands. It just seems like there are so many people involved. And so I want to hear about the things that you have done and what you as an individual surgeon can do, or what we as individual surgeons can do. But then I want to talk about sort of the next level and the next level above that, about what needs to happen. Because we hear that a lot. Like, as a kid, that's when we started recycling cans and we were going to save the planet. And if you saw someone throwing a can in the trash can, you were just like, do you hate the earth? And then you realize the recycling programs maybe aren't as effective in doing the things we thought they were going to do. And so, as an individual, we really want to do the right thing. But I want to talk about the things we can do as individuals, but I also want to talk about the impact of what one person can do and the impact of what one hospital and, what needs to happen to make the impact that we want to see.
Yeah, definitely. I think that you hit the nail on the head. There's the individual level of what we can do as surgeons, which is actually pretty powerful when you think about all the decisions that have to be made. And then there's what we can do on an institutional level. And then there's really what we need to be doing as a healthcare system as a whole and pushing for regulatory change, probably from the federal level to get things to change. And a lot of that, like you said, is going to be that reduce, because recycling is great, but it's also energy intensive. And so whatever we can take out of the system to begin with, probably on all three of those levels, individual, institution-wide, and on a federal level, is really going to help cut our carbon emissions.
But then even internationally, right? We see our colleagues at our international meetings from India and China, and it's like, once you think you've got it figured out, it's like, wait, there's just so much more happening. But yeah, it's a big job. But talk to us about, again, individual steps we can take, and then what's after that.
Yeah, and just to mention our international colleagues, I mean, this is where we can really learn a lot from them, because our colleagues in India, for example, are really on the forefront of reusing instruments and showing that it's safe and effective. So this is an area, it's a uniquely American problem, and we have a lot to learn from our colleagues. And the thing that I always quote is the U.S. produces about 27% of the global healthcare footprint, but we only have 4% of the world's population.
So American.
Per capita, our carbon emissions are super high. And
We're
I think that's
one.
Been that long-term push towards single-use instruments, which has not only come from industry, but also come from our regulatory agencies who, without evidence or data, have encouraged us to go
So that's the question.
use.
Does doing all of this stuff, having all these single-use instruments, all the paper gowns, or not paper, but the likely plastic, at least derived from all the bad things, the gowns, the gloves, does any of that make our surgeries safer, better outcomes? And my guess is you probably have the answer to that.
Yeah, not that we know of. And the evidence is out there. There was a really great study out of City of Hope, which is a cancer hospital here in Southern California, that looked at pre-pandemic, when they had everything known to them. They had the disposable head covers, shoe covers, single-use face masks, and they looked at their surgical site infection rate before, and then they looked at their surgical site infection rate when all of those things went away. When they're having to reuse masks, they're using cloth head covers, there's no shoe covers. Their surgical site infection rate not only went down, it went down a lot. It went down by about half. And their number of cases went up, and their number of contaminated cases also went up. As you can imagine, cancer hospital people had to delay some care during the pandemic, so their cases actually got more complicated. And what they did note was that because there were fewer disposable items, they noticed there was a huge increase in hand washing, which we think we always do all the time perfectly, but there's still always room for improvement. There was a big increase in hand washing. And so kind of the bottom line was that none of these disposable things actually made the patients any safer, but our behaviors in hand washing and not relying on those disposable things actually did make the patients safer.
Oh my gosh, this is so reminiscent of who was it who went from the anatomy lab to the wards, and it was like was it Lister?
I think it was Lister, yeah.
Yeah, or in Semmelweis. I can't remember. It was like it's like hearkening back to those kind of stories. But
I was thinking that, but I couldn't remember the names, so I wasn't.
Yeah, I couldn't remember the names. But anyway, the thing is, I did want to just mention that I did a deep dive on this for a review, and looking at the data, there aren't really great data about like how single-use instruments are, like their function after they're recycled, and put back in. But there was this one that looked at laparoscopic appendectomy and looked at the burn radius, and it was comparable. It was like 1 versus 2 millimeters. And basically what I do know is the ACOG statement on recycling, single-use instruments is now withdrawn.
Oh,
yeah, they just withdrew it. So in any case, because it's pretty negative, but many of our health systems are doing it anyway because, and then, there was this whole movement about, when it first started up, in terms of concerns of safety versus cost and durability, et cetera. And I think, the systems are doing it anyway, number one. And number two is right now with supply chain issues that we literally have access. I mean, they just pulled LigaSure, told us to use alternative LigaSures in terms of bipolar. Yeah. We don't have the blunt tip. We have to use they don't have
Maryland
the 37.
tip.
Yeah. They don't have the 37, whatever it is, millimeters or centimeters. And then we have to use the longer one or the Maryland tip.
Not good ergonomics, Amy.
I know. It's true.
But you're exactly right. So, 2 points there is if you look at the history of reusable and reprocessed instruments and you go way back, I mean, it used to be people making things in their garage and then like bringing them in to use them and sterilize them. But actually since 2000, the FDA has been regulating reusable and reprocessed instruments. So they go through the same kind of safety and efficacy analyses that single-use instruments do. So to your point about the ACOG statement, which was very, very negative about reprocessed instruments and said we should even be disclosing it to patients that they might not be as safe, even though there was no data to support that. I'm really glad to hear they pulled that. And it may be in response to the new federal regulation, which was put forth in December of 2021, or it was an executive order saying that all federal facilities had to decrease carbon emissions. That included things like VA, hospitals, and Department of Defense. And they previously had a rule saying they would not allow reprocessed instruments into their facilities, and now have done away with that rule in order to help meet some of the carbon restrictions. So I'm hoping it was in response to that.
Is it less impactful on the environment? Is there less of a negative impact to reprocess versus a new instrument? I mean, like the process of cleaning, I'm sure there's chemicals involved and things like that. But is it like in our cloth gowns, Gore-Tex gowns, better for the environment than, disposable gowns? Because the VA does, when I operate the VA, they do have, I think, Gore-Tex or whatever it is, it's reusable gowns.
Yeah, the reusable gowns, and a lot of hospitals got rid of them because they said, well, the energy costs and the water costs were too high. But when you compare it head to head to something like a disposable gown, which is actually a petroleum product that's not recycled and goes right into the trash, the carbon footprint of that is higher. And yes, it is still carbon intensive to reprocess an instrument. But if you think you're still preserving some of those, rare earth metals, you're preserving any motors that are there and reusing those. So it does produce a lot less waste and a lot less processing of waste on the, at the end of the use.
I think one thing also that I noticed when I was talking about the or researching the single-use instrument reprocessing issue was the fact that many of the white papers, if you look them up online, they're actually funded by many of these companies. So it's like, there's definitely some self-interest in there. And then honestly, I thought I came around on this topic myself because when I first was handed these reprocessed instruments, I thought it was disgusting. And then one of my partners was like, I operate in Rwanda, and the cost of one of these instruments is just astronomical, and reprocessing them makes just so much sense environmentally. And I had to check myself, and I thought, wow, this is such a thoughtful thing that I hadn't even considered. And then in the whole time that I used it, I didn't have a problem with the instruments. I will say that there's probably a carve out for the endoscopic instruments that's used in the duodenoscopes. There was a big problem at UCLA, but I think for our stuff, it's not really an issue.
But if you ask a surgeon, like, did you notice that we were using the reprocessed instruments? Like, oh, for sure, it was just not nearly as good. And like, but you're saying the data says it's about the same. And I think a lot of it is just trying to educate to change attitudes about these things. And part of it is educating us both on the environmental impact and also the cost. I mean, cost of these instruments, I mean, like you said, Amy, the industry is making money on these things being one use, right? They make a lot more money if we buy 10 than if we buy one. And so having an opportunity to educate those of us out there that don't know these things to allow us to go back to our hospitals and say, listen, let's be smarter about this. And hospitals love hearing cost-saving measure ideas. Like that's their favorite. But if there's also an impact to the environment, then, I think it would be even more, it would be even better. But I guess the next question is, so what's the incentive for these companies to make the best reusable instruments, right? Like how about, I mean, because, we're buying one now, right? Just like a reusable bipolar grasper, right? Like, do I need to use any reusable instruments? And the answer is not necessarily. It depends on what's out there, but why not invest and just make the best possible reusable instruments for these cases? Because it's probably not very financially intelligent from a business standpoint, but like, is that on us to motivate these companies to make these instruments?
Yeah, I would say so. They are not incentivized to make reusable instruments, and most of their sales models are going to be on units sold. So it behooves them to sell a brand new, fresh instrument at the maximum price every single time. They're also not responsible for the waste of that instrument. So what do they care? They're just trying to get it on the shelves. And it's historically also been really hard to get hospitals to invest a lot of capital, right? So it's always much harder to get them to buy something reusable because it's a lot of money up front, as opposed to saying, oh, this is just a single-use item. We'll refill your shelves when they're gone, et cetera. But oh, by the way, you're going to be responsible for the extreme waste that's going to come out of that product. Nobody accounts the end use into the final cost. So there's no incentive right now. And I think it's on us as surgeons when we talk to our reps, when we talk to companies, say, I don't want another disposable product. It's not innovative to me to make another disposable product. I don't want to buy a disposable product when something reusable is much more innovative. But I do think it's going to come down to some kind of regulation, whether hospitals push back on the companies and say, you're going to be responsible for this waste. Okay, that's going to change their model. Or if regulations come down to hospitals and we are going to have to reduce our carbon emissions, which we will, we're going to have to figure out how to do that. And it's not going to be this endless consumption that's just not going to be okay anymore.
I think it's going to be like they've done with bundles for like orthopedic surgery, right? Initially, it was like, I'll buy whatever hip I want, and the hip reps are going to try to sell the most expensive one. And then all of a sudden, CMS says, actually, we're going to give you one price for the surgery, the hospitalization, the hip, and any complications. All of a sudden, everybody's going, oh, wait, actually, let's get a cheaper hip. Let's have our patients head to rehab more often. So I think if you put the onus on the whole group, the surgeons, the hospital, insurers, all now have skin in the game when it comes to waste. But until there's regulation, like you said, at the federal level, it's going to be hard because everybody's going to have their own incentives.
Right. I think now is a really good time for us to begin the move to push back because of supply chain issues. I mean, there's always, and to Amy's point about the white papers, yeah, they're PubMed index papers that are written by the companies or sometimes even say a company's perspective. So you know exactly who the author is. And some of the points they make are that, oh, well, single-use items are always reliable. They will always be there for you until they're not. And now they're not. And the ligature is gone for a while. The Cooper Surgical Roomy tips were gone for a while. So one thing, one opportunity I found in this supply chain shortage is the company gives you no option. They just come in and say, sorry, we don't have it. So I found reusable alternatives to, using the Roomy. And then when their supply came back in, I said, well, why would I switch back to this disposable item?
What's your alternative?
Have you ever heard of something called a Pelosi or a Valchev?
Yes, but I can't find them. Like everybody at Pitt who trained is like,
yes,
they will bury me with these Pelosis. I will never give them up. I hide them like because they don't make it. I heard they don't make them anymore.
Yeah, I trained with a Pelosi.
Yeah, I also trained with the Pelosi. So it's funny how, we grew up with all of these reusable items and now they're not available anymore. There are some manufacturers making lookalikes or Valchevs, but my hospital was able to find 3 in the storage closet and dust them
that's what
off
I've heard. People like, just go dig deep in the OR supply room and you'll see a couple of. I've actually done that. I've actually gone like snooping around, and I haven't found them in my hospital, but maybe there's another hospital we work at that has them. But like, is there nobody that wants to make this instrument? Hello out there, anybody want to? Make this thing we all want.
The clinic and the hospitals have all sorts of stuff in the back, like chambers. Like I got an email. Yeah, in the closet. But one of the head nurse at the clinic in our institute was like, "Do you want this anoscope?" I was like, I asked our group, "Does anybody want this anoscope?" And everyone was like, "No. Why do we even have one?" It's like
made out of wood.
No,
from like 1902.
I'm glad to hear it's everywhere. We'll find hysteroscopes. It's still in the boxes that were never opened. I mean, these are valuable products that we can use. But the other thing I did, I got my Pelosi's, I'm using them now, and then took the opportunity to go to the company and say, hey, you need to make me a disposable tip. Your supply chain's not reliable. You left me out to dry. I switched to something else.
A reusable tip.
A reusable tip. Why I'm already autoclaving the Roomy here. Why can't I just autoclave a set of tips along with it? So this is our opportunity now that companies are no longer reliable to push back and ask for reusable products.
That's a super interesting point, Kelly, because, I just want to take a little detour and say, I think it's super important for thought leaders like you, like Mark, like myself, to try and liaison with industry to make meaningful change. And I don't think it's bad to have industry affiliations. I think it's super important to have, especially women at the table, to talk to industry about these issues, about having a diversity of standpoints. And I don't think it's something that viewpoint is not prevalent among urogynecologists. But I think among the minimally invasive gynecology crowd, you guys are way more open to industry ties. And I think it's a conversation, right?
Are there any green companies? Are there any biomedical companies out there making things that have a green mission, right? Like that's something that, like, if you're doing a startup, like right now is a really good time to be a green biomedical startup.
Yeah. If you're out there, contact us. You can gauge because
let's just start it ourselves, since I know so much about starting.
Companies might have
nothing about it.
They might preach sustainability initiatives out of one side of their mouth, but then go on the other side. And
it's not a good business model to make something that works really well. If you're in the business of selling things.
It's true. It's not. And going back to Amy's point, working with industry, yeah, I think it always had it's a stain on it, like, oh, you have conflicts of interest. If we don't work with industry, what's going to drive their product development? It's going to be marketing. And what's going to drive marketing? Sales. And what's going to drive sales? Single-use products. So we really have to get out there on the consulting and development side.
You do quite a bit of that, right?
I do. I really like it. I think it just started because I'm always very critical of products. So they said, okay, well, why don't you come show us what you think is good? And
I cannot think of anybody better, honestly, to do that job than you, honestly. Like you're always honest. You're always so thoughtful about your ideas with these things. Like I'm sure like there's plenty of guys in those meetings after you start talking who are like taking notes like, oh boy, we got to really rethink this because Dr. Wright's got some really strong opinions about everything we're doing.
And I do think my opinion is different than a lot of the things they hear. I think they do get a lot of placating opinions or, yeah, this is cool or whatever. And I would say, is it too complex? It's too disposable. It's too wasteful. It's a solution looking for a problem. Those kind of things that I think we need to pull back the reins on industry a little bit and say, hey, make things that are actually good for us and good for patients too.
It does feel, though, so overwhelming in thinking about like making these instruments, but with supply chain especially, one of the things that I, learned in my sort of toe dipping into the administrative side of things in healthcare is like there's like 3 suppliers for like everything we make. And like if we, want to get a good deal on a particular laparoscopic instrument, well, that's fine, but we get our saline bags and our drapes and our shoe covers and our hats and from this company. And so we have to use whatever device they make because it's become the Walmart of healthcare, right? They're just economies of scale. It's these massive, massive corporations now. It's not simply, I want this instrument. It's like, oh, well, you can only choose one of these instruments because they have cheaper saline bags or something. And it's to think about upending that industry seems extremely intimidating.
It is. It can seem overwhelming. It can seem kind of hopeless. There's people's jobs. This is their job. We have a head of supply chain. It's their job to make contracts with distributors and companies that do this. But I think we can have that voice for our institutions. And it's interesting how little power sometimes we feel that we have, but when we are passionate about something that actually helps the institution as a whole, both from an environmental side and financially, people start to listen. So going back to the individual, the institutional and the kind of federal level, I think on an individual level, hospitals do want to start making us aware of our institutional costs. And I don't know if you get these too, but we get reports on what we use in the OR and how much they cost. So they're giving us this data, but then, okay, it's great data, but what do we do with it? Right? So you can take that, you can go to your value analysis committee, you can go to your head of supply chain and say, okay, well, I want to cut costs on this. I don't want this instrument. I want to use something reusable. Help me get those things in. And these are the individual choices we can make as surgeons that actually will make a difference when it starts kind of steamrolling and more people get involved. And it's the same thing with triaging waste. I'm surprised that just me as a surgeon doing a QI project with a resident were able to push an institution to get really interested in this test of change and doing a better job of triaging our waste. So when I came to my current institution, I was used to having one red bag, one red kick bucket in the OR, and I went to every bag in the OR being red. And I was just so sad about this. I said, we have to make a change. It wasn't even in line with our policy. It was just something that had been done as a reaction to a mistake in waste triage, that had happened like 8 years ago. So getting the parties involved and getting our environmental services involved and our nurses involved and other people saying like, yeah, we see this every day too. This is terrible and ridiculous. And then them doing so much work to put in this change, but still saying, oh, Dr. Wright was the driver of this. And I'm like, I'm just the one who was kind of loudest about pushing it along, even though all these other people have the jobs and have the infrastructure to make the change. So even if it seems overwhelming, I feel like we can have a voice within our institutions when your goals are aligned.
It's very inspirational because I think a lot of times in this job, it does feel like, there's just so many moving parts. It's hard to feel like you have the opportunity to make that kind of impact. And I love hearing your story. I love hearing that, like, I'm just going to do it. I'm just going to show that it works, and I'm going to inspire people around me and everybody. It's hard to argue when it's all to make the world better, and everybody kind of like does it with you. And I love that. So, I mean, kudos to you for just not only doing the work and the research, but inspiring people around you to do it too.
Oh, thanks. And then, you become interested in it and other people become interested in it too. And the hospitals have infrastructure to do this. Everybody has a safety officer. Everybody has a nurse educator. These systems are in place to help us make this change. And we need to start using the data that's out there and the evidence to show actually air pollution, heat, climate change is affecting our patient outcomes negatively. And we need to make a change. I think that's really powerful. Nobody can argue with that.
I think that one of the things that would be really helpful for the next step paper that you write on this, Kelly, or the paper that you write up on this with the resident is just like with ERAS, the enhanced recovery after surgery, the playbooks on how to implement the change and obtain buy-in from stakeholders. Like, how did you leverage these positions of leadership and the infrastructure that is already existing to leverage that change? Is super interesting to me about what you said about the nurse educators, about the chief quality and safety officers, about, we have surgical operations.
And then to show them the cost savings at the end would probably be extremely powerful.
It took 1 month of cost data to get everybody on board is what it did.
I'm sure.
But, yeah, it does feel exactly like ERAS. And I did that at my institution too for our division. So I had already been through a little bit of this quality improvement process. But I think it was reaching out or finding out. First of all, you have to find out who these people are. I mean, most of us don't interact with them on a day-to-day basis. I didn't know there was a head of linen services at my hospital, but there is a head of linen services. And that person is in charge of some of our recycling and our cleaning contracts. So just trying to find these people, reaching out to them, telling them what you're interested in and how there is a growing movement kind of on the ground, and then getting them in the operating room. So Amy, like you said, when the human factors group came in and they were just astounded by how much waste there was in the operating room. It was the same thing with some of our higher level quality and safety officers. While they have the numbers and while they see the amount of tonnage of waste going out every day and every week, that's not conceptualized. And then when they see it in person, it becomes something tangible to work on. It's actually bringing them in, inviting them into my operating room and showing them what it looked like was really, really helpful in the process. And you find out, like everything, the people at higher levels don't necessarily know what's going on the ground. Like your head of your institute doesn't know what you're doing every day. But when you show them, it can be really impactful.
Can you go into that federal level regulation a little bit more in detail? You've alluded to it a couple of times, but just to give people an idea of what does that entail?
Yeah, I always think what comes down through the federal government is probably also going to extend to all healthcare institutions and providers. So the executive order that was put out applied to federal healthcare facilities, and that was to be carbon neutral, I believe, by 2035. And so you can imagine that if our federal hospitals and VA system are being subjected to these regulations, and maybe Medicare reimbursement's going to be tied to it, then likely it's going to expand to other institutions. And we need to start thinking about these things now. There's no specifics put into place, but we need to start thinking about these things now, how to become carbon neutral over the next decade, before these regulations come down and we're forced to do it at the last minute. Clearly, it's better for us and better for the world if we can do it as soon as possible. But also from a regulation standpoint, it's just about being prepared.
One other thing that I want to just circle back to is, what exactly do you put in the red bag?
Yeah, great question. Probably should mention that. The red bag is biohazardous waste. It is only supposed to be tissue and blood saturated items like liquid blood.
So like a bloody glove, a bloody gown, dirty, that's not red bag.
That's not red bag. Things that are blood stained, things that have stool or urine on them are not considered biohazardous. It's
That's more
only
for Amy's
supposed to
practice
be.
than mine, though.
Yeah.
Stool and urine, thankfully.
Right.
Or any, if you think about it, any new parent at home is dealing with diapers and, throwing all of that into the regular trash. That doesn't go into biohazardous waste.
You're
So
not supposed to. You're supposed to flush the duty before you throw the diaper away, which nobody does. But you're not supposed to throw the dirty diaper away with all the poop for that reason.
Oh, that's good to
But
know.
my wife was insisted on using the washable diapers, and I was like, "Why would you do that with twins?" It actually wasn't hard, and I think the kids liked it. It was really soft, but yeah, you separated it before you washed it.
Much better for the environment. Thank you.
So much. It was honestly, it was great, and the diapers were really cute too because they had little patterns on them and stuff.
But yeah, if you think about all that, everything we throw away at home that doesn't go into biohazardous waste should not go into biohazardous waste at the hospital too. And biohazardous regulations are usually determined by every state's Department of Public Health, but they're pretty consistent across the board. What I can say is they're also not evidence-based, and most of these regulations came out of the HIV epidemic. So it was really based on a lot of fear of blood-based products. Yeah. Nevertheless, it is the rules and regulations we have to follow. So we should follow them, but we shouldn't overdo it and think we're doing something good. Because we're not doing something that's evidence-based by throwing things into the red bags that really, really shouldn't be there.
So one other thing that I got to think about with just waste and those kinds of things is something that I think about a lot as a MIGS surgeon, and that's OR efficiency, high volume surgeons, like being in the OR less time, having our patients in the hospital for fewer days, like getting them home. They're not using hospital resources. They're not using, that to me seems like an opportunity for impact for us as well, as changing not just how we function in terms of waste management, but how we practice our job and how we, as departments, as divisions, as hospitals, triage and organize our patient throughput to get the right surgeon, right patient, right time. Because, and y'all wrote about this too, anesthesia gas and all those things have a pretty significant greenhouse gas impact, right?
Yeah, significant. And that's really unique to our field. But you're exactly right. ERAS goes along with this too, getting patients out of the hospital where they're in, the most utility intensive area that they could be in, getting them home, getting them out of the OR, and then doing HVAC setbacks for areas of the hospital that aren't being used, which just means turning down the temperature to a neutral temperature when no one's using that area. So all of those things are really important. And I think that should be driven from us from a process side. The hospital may always be full, so it may not be a huge impact from the institutional side, but on an individual level and for the patient themselves, that's a huge impact for them.
Well, I was just going to make a point about the outpatient surgery side. We have a urogynecology outcomes page, and you can see this on our website because I review this every year as a section head. But as we transitioned from going from inpatient to outpatient, our outcomes got better. We're just doing too much stuff to them, like fluid overloading them, doing the opposite of ERAS, like less. We just got less.
They're up walking around more. They're not laying in bed for 24 hours. I'm sure VTE probably went up inpatient.
Yeah, they're just doing better by sending them home. We're just iatrogenically causing some of these problems probably.
I truly believe it. And Mark's exactly right. To go home, you have to get up and you have to walk in the door. And so people get mobilized right away. Then also I think they have their comforts at home. They can take Tylenol when they want to. They can eat what they want to. If they want to partake in something else that's legal but not used in the hospitals, they can, so it's, I just say legal in California, which is, it's been a problem sometimes for inpatients. But yeah, so there's a lot to say by getting people just back to normal, back in their own homes, and that significantly reduces the resources that we use. And yeah, the resources that we're using for them are not necessarily giving better patient outcomes. So
I
As
think
a
that's
MIGS,
the biggest thing is that culture change, right? I think,
Yeah.
good Lord, the fights that happened in our hospital when they took away the cloth hats. I mean, that was like, and there's no data, right? Because that was AORN, right? It wasn't like the nursing
Yeah.
paper
Yeah.
saying like it was, and there's zero data on that at all. But like
zero data.
Well,
but the
now
nurses
there's
were like, but AORN says, and so they just
there's papers now showing that there's no difference.
Yeah, in the
right. But
aftermath,
there's never data to support it. But
Yeah.
people
there was
were
never
freaking
data to
out.
support it. Yeah.
But people lost their minds about the hats. And so I feel like this, people are so passionate about the cultural parts of their job. And so it is hard to convince people that reusable instruments are just as good and they're just as clean and they're just as safe. And there's some people, it's just a challenge to get them to believe data. And we see that every day on Twitter, in other arenas as well, that people have a hard time with facts. But I think in healthcare, we should be the ones to go, okay, data says it's fine, we should be doing it.
Well, the other thing that I will say, though, is in terms of really heartening data, I can't remember where the study was published, maybe JAMA Surgery, but they surveyed surgeons on whether or not they would be willing to do things to mitigate the amount of waste in their OR and essentially engage in more sustainable practices. And the rate was astronomically high. It was like 95 or 99% or something like that.
I was going to say it was over 95%.
Yeah, it was. I mean, surgeons are on board with this. And if it's just like throwing things in a different trash can, that's easy. I mean, changing from...
What a great resident project, though. Good for you, Kelly. This is such a cool idea. I think there's so many ways to do this. For QI, our residents all have to do QI projects now. Like, it's a great way to do good by doing good work. And it's like everybody wins, right? Like, you get your paper, you get to present, you get to make the world a better place, you get to reduce costs. Like, no one's going to not want this to happen. I mean, everybody's going to want that. And I think at the end of the day, money drives all of this as much as we like to. And that's the thing I learned, I think, working in my ACOG health, economics committees, is it's not always about what we think or even what we know. It's about what it is. And if we're not financially incentivized to do it, or if there's not cost savings, as much as we want things to happen, they don't always. But this actually seems like something that would be extremely cost savings, reducing waste, fewer red trash bags, reusable instruments. I mean, not having disposables would save the hospital a fortune because we're getting the same number of dollars per case, whether we use one instrument, 10 instruments, or no instruments. I mean, it's the same fee. So, the ceiling isn't getting higher, but if we can lower the floor, we get to keep the difference. That's a huge, huge incentive for hospitals. So I think there's, for a company out there that wants to make more reusable stuff, I think hospitals are going to be very, very interested to buy these instruments.
And, there's a lot of cost cutting going on right now. I mean, there has been probably for the last decade, but I think hospitals are feeling the strain. And so where they can cut costs for something that is only going to take education or maybe changing the process a little bit, it makes a huge impact. So there's some resources online, I think, for physicians and hospitals that want to look into this or promote this to their hospital. And one of them is Practice Green Health, which has actually a hospital consulting service. They'll come in and do an audit to help hospitals, show where they can improve their carbon footprint and save money. And they also have a physician side. And then there's Healthcare Without Harm, which also has physician resources. So they work together to provide resources that are already there. And like the Red Bag Project, reducing red bag waste, they have, a PDF file on all the things that you can do in your hospital to help reduce the red bag waste.
It's a great resources. And we'll put all this in our show notes as well for our listeners.
Processes are there. Yeah, the evidence is there. The data is there. I mean, if you look it up, if you look up the bouffants, if you look up the shoe covers, if you look up where the scrubs are laundered, if you look up single-use items, even heart catheters, the data is there that they're not beneficial for patient care. So I think we just have to reiterate that over and over. And I think people aren't aware that the data is there. And so they'll come in, AORN will come in and make these recommendations without any data. Or the Joint Commission, unfortunately, will come in and make a lot of recommendations that aren't based on data. But we really have to start pushing back on that and just putting it out there over and over and over that the data is there and we need to follow the data if we really care about patient safety.
This has been so much fun. This has been so good and informative. I'm all fired up now. I'm going to do it. I'm going to go back.
Woo-hoo.
University of Kentucky. All right, guys, listen up. All right, y'all are just throwing money, just setting money on fire. Here's what we're going to do. And we're going to, when you tell people how much money you can save, they're like, okay, go on. That's how you get things to happen in healthcare. And this is exciting. I think it's one of these things you go, oh, wow, I think we could actually make an impact. I don't think I have to just whine about it all day long. I could actually go back to work and do something. I mean, it doesn't happen very often, where you get to learn something and go, oh, wow, that's actually super, super powerful and also doable. A couple people can make a big impact as you've done. And not to say what you've done was easy, because it doesn't sound like it was at all. But a lot of the groundwork that you've laid, a lot of the work that you've done is going to allow someone like me to be able to go back to my institution and try to recreate some of the success that you've had. So it's just so inspiring. Fantastic work.
Steady, unrelenting pressure.
I always tell people about myself, never underestimate the power of being annoying. Just keep asking and asking and asking. But if it's important to you, and then it'll be important to other people, I think. But
well, it's an example of just where the interest of the patient, the physician, the institution, and the cost savings all align. So it just makes sense.
And with the environment, right? It's rarely is every single bit of it for the good, unless you're making disposable instruments and you're trying to shut this conversation down. But besides those people, everybody else is going to benefit. No, that's right, Amy. I think you're right on.
Well, thank you so much, Kelly. It's been super illuminating. I love your ideas and just thought leadership in this space. And I think this work is going to make a huge impact for everybody. And again, you're the perfect ambassador to just bring it in a very understandable fashion. I'm like, oh,
and she does it every day for her 12,000 plus followers on Twitter. Migs Lady, Migslady.
No, Migs Runner. Migs Runner.
Migs Runner. No, Migs Runner. It's
the
Kelly
residents
Migs
call
Lady.
me Migs Lady. Yeah.
Kelly Migs Lady, right? Yeah. So Migs Runner, because you don't do enough, but you have to run marathons too to make me feel even worse about myself.
Yep, that's why.
Migs Runner. I mean, every day you bring the knowledge on Twitter and you share it, and it's the best. And I don't know of a better Twitter follow than you. So
thank y'all.
Thank you so much for coming on our show. We're excited to be able to do this show and bring in guests to be able to share with our listeners all the great things that our friends and colleagues and the great people in our field are doing to share that with our listeners. So thanks so much for making time. I know you're busy. I know you've got a lot of things. You probably have to go run a quick half marathon before dinner or something.
Nah, I ran this morning. It was all good.
What was I thinking? No, it means a lot that you came and chatted with us. And I know Amy would say the same thing, how grateful we are to have you both as a guest, but also as a friend. And so thank you so much. And we look forward to seeing you soon, December.
Can't wait to see you all in person. Yeah.
This is going to be great. Awesome. All right.
Thank you so much.
Thank you again for coming on BackTable OBGYN. And we appreciate you coming on.